All right, so we are recording. Before we get started, does anybody have any questions or announcements that you'd like to share? Nope, you guys are quiet. Okay, well, you can use the chat box or interrupt me at any point if I'm going on and you need to say something. Just jump in and I will pause at different points, and you can always ask questions or say a comment if you would like. All right, so we are at the top of session 14. After today, we will not meet live again before the final. I'm going to post information tomorrow about how you're going to go through the deep dive presentations, and then that will be asynchronous. It's listed as 2 sessions because there's that much work for you guys to do and viewing each other's. After that, a week from tomorrow, we will have the final exam. It will be the same format as the midterm. It is comprehensive, and it will be roughly half. I'll say roughly, I'm trying to remember. I think it'll be roughly anywhere from a third to a half from the first half of the class, and then the remainder from the second half. So to study for that, I would advise go back through all the note-taking guides and look at those learning objectives. They're there for a reason, and that's how the final is designed around those specific things. And make sure you filled in those note-taking guides, and remember retrieval practice. So make yourself tests, make flashcards, get somebody to call it out to you, talk about it with your classmates, those kind of things. Don't just reread the notes and look at the PowerPoints again, or just watch the recorded sessions, because that won't really get it into your brain as much as you need to. The other thing I don't want to forget to tell you is there's a quiz due, but it's not due until next Tuesday, the June 9th. So you have a while for that. It is going to cover information through the end of class today. And like the other 3 quizzes, you can take it twice if you want. The most recent time that you take it, that's the grade that will be recorded in the grade book. So it says all that on the instructions, and it will release at 3 o'clock today. So you'll have almost a full week to take that. I would suggest you go ahead and do it sooner rather than later, because it will help you study and prepare for the final. The only other live synchronous session that we have after today will be the debrief, because the final exam is going to be just like it was for the midterm. There'll be a period of time that it'll release, but we won't meet on a Zoom. So I'll post all that so you have it in writing and it's clear. I just thought that might be something you guys are wondering about, so I thought I would preemptively answer those or speak to those points so you know what to expect. All right, so let's move into today's material. Today we are going to talk about something called social determinants of health. And I want to relate that to what we've been talking about in this course and the nervous system. So we're going to go through this, and here's what I'd like for you to get from this class session, including what the preparatory work that you did, and our discussion and what we go through today. I want you to be able to identify the components of the brain that are related to stress and trauma, describe what happens in the nervous system when somebody is exposed to chronic stress, and then define health disparities, social determinants of health, and those other related terms that are on your note-taking guide and that I'm going to highlight for you today. So remember with that, I don't want you to memorize the definition. I don't want you to just parrot what I say it is. I want you to understand it and be able to explain it to somebody else, preferably somebody else who isn't familiar with the term. So it's better if you understand it and can talk about it in sort of everyday language when we get to these certain terms. All right, so I want to start off today, though, I asked you all to come to class prepared to do some sharing about the preliminary materials, the prep work for today. And I apologize for, I don't know if anybody saw the video that was posted on the outside. That was something another educator shared with me, and I did not fully review it, and I should have. I will not make that mistake again. It had some unsavory language in it that was completely unnecessary for the point. So really what I wanted you guys to do is there was a short 3-column reflective activity, and then to go through, really peruse the page on the AOTA website. That's the MDI toolkit. And I'm going to put you guys into breakout rooms, I think, in just a second. And what I'm just going to give you about 5 minutes to talk with each other about those materials and your thoughts or what you know so far about social determinants of health. So if you give me just a second, hopefully it's going to let me, well, I'll stop the share, that'll help. Yep. Okay, so I'm going to put you in breakout rooms. Let's see. Here we go. So I'll give you 5 minutes and then everybody will be pulled back into this room. So you're just going to talk about the preparatory materials and what your ideas or thoughts or questions are about social determinants of health so far. Here we go. Carly, are you there? There you go.
gonna listen to the whole thing?
Let's see. I think we got. Yep, I think we got everybody that was in the room. Okay. So we are going to watch the video, and rather than embed it in the PowerPoint, which makes the PowerPoint take up a ton of memory space, I just put it on straight on Blackboard. So we're going to watch that and learn about the social determinants of health.
I'm going to talk to you all today about healthcare. And healthcare obviously is something that is, we're right around a election, and healthcare is something central to everybody's concern in many ways. But I'm going to talk about it a little differently than probably how you think about it most of the time. You know, we think about healthcare, we think about insurance, which is obviously important. We think about getting our flu shot, which is important. We think about getting our annual checkup, which is important. You should do all those things. But I'm going to talk about what's known as the social determinants of health. And I'm going to get into that in a little bit greater detail in a second. But when I start, I want you to think about healthcare as a civil right. And once again, that's something we hear about a lot, especially around election time, is healthcare a civil right or not? What I'm going to talk about right now is that healthcare, and we don't think very much, was part of the civil rights movement. And healthcare came directly out of the civil rights movement in many ways, our current healthcare system. Dr. King talked about healthcare, and we don't think, once again, about healthcare in the civil rights movement. We think about voting rights, we think about desegregation, we think about schools. But healthcare was very central to what a lot of the civil rights leaders were talking about. Dr. King talked about it, Malcolm X talked about it, Fannie Lou Hamer talked about it, the Black Panthers created healthcare clinics in Oakland and in many places. So healthcare was very central to the message of what was important to civil rights. And so, this is not a new thing when we talk about healthcare being viewed as a civil right. And during the civil rights movement, there was a group of physicians, black and white, northern and southern, the group called the Medical Committee for Human Rights. And what they did is they traveled throughout the South, mainly in Mississippi and Alabama, in 1962, 1963, 1964, 1965. And they patched up the civil rights workers. You've all seen images of civil rights workers getting beaten up. Well, doctors didn't treat them in the South. Hospitals didn't take them in. We didn't have a Good Samaritan law back in the 1960s. So they were not treated. So this group of doctors traveled around the South, patched them up, took care of these civil rights workers. But what happened as they were doing this is they were traveling throughout the South, and they were patching up these civil rights workers. They got very frustrated. They saw the good work that these civil rights workers were doing. They saw that they were fighting for desegregation, fighting for voting rights, all the things that we think of when we think of the civil rights movement. But they also saw the deplorable conditions that the Black community and a lot of the white community in the South was living in. And these doctors literally sat around at night in the hotel rooms. They're saying, what are we doing? What is this fight for if people don't have enough to eat, if have any adequate health care, people living in conditions that are unhealthy? And so they started to think about what could they do. And the father of this movement is a guy by the name of Dr. H. Jack Geiger. And Jack Geiger was one of these physicians, one of the members of the Medical Committee on Human Rights. And Jack said, we've got to think about not just treating people, not just trying to make them better when they get sick, but alleviate the conditions that make them sick. And so he talked about the social determinants of health. What are the things that make people sick? And what can we do to alleviate them? Because what he saw were conditions as he traveled throughout the South that were making it a situation that people couldn't get better. He said, our job isn't just to get people better when they get sick, but to prevent them from getting sick in the first place. And so he first, with some of these other doctors, started a small clinic outside of Jackson, Mississippi. They basically did that out of their own back pockets. They said, that's inadequate, that's not enough. So then they went and they wrote a grant. This is during the Great Society and the War on Poverty. And they got a demonstration grant to start the first 2 community health centers in the United States, one in Mississippi and one in Boston. And we now have 2,900 community health centers in the United States. It's the single largest way that people get health care in this country. 27 million, I think, people now get health care through the community health center. And it comes right out of the civil rights movement. And one of the things that Jack wanted to do was deal with the problems at the grassroots level. And the first one he dealt with was poverty. And when he was in Mississippi, he set up the first community health center in the South in Mound Bayou, Mississippi, and dealt with basically sharecroppers in North Bolivar County. And he dealt with conditions like this. And you know, this picture is very powerful. It's also very illustrative, because one of the things that when Geiger set up his first community health center in Mississippi, he knew statistics. He knew that maternal and infant mortality rates in Mississippi were terrible in 1966, 1967, 1968. So he recruited pediatricians. He recruited people to come down and do these things. But what he found out was that there were other problems he had to deal with. And I said, this picture is very illustrative. This is if you can see, this is a stove. This is a sharecropper shack, and it's a stove. It's a stove made out of a 55-gallon drum that was, you know, left on the plantation. That was the only source of heat. The first winter the health center was open, they had all these small children that were coming in with burns, and they weren't ready for burns in Mississippi. Why are we getting all these burns in Mississippi? And it turns out that this is how most houses were heated, and so kids were running into it. So they went out, they said, we can't just wait for people to come to the health center. We got to get out into the homes. And so they started building little fences around the stoves. That eliminates a problem, right? But then they said there's a lot of other problems. The roofs leaked. We got this quote from Dr. Brown, right? It doesn't do any good to treat someone and send them back into an environment where they're going to get sick. There were no screens on the windows. People were getting diseases from mosquitoes. There were holes in the floorboards. There were snakes. There were rats that were getting in. So they set up a system just to fix up the houses, right? Because poverty has a tremendous impact on someone's health. And there are obviously lots of reasons, many of which we don't have time to go into, but this is just kind of an example. And so this is the 1960s, but today, of course, we still deal with poverty, and poverty still has a huge impact on people's health. Recent UN report on poverty in the United States, saw Alabama as the most impoverished areas in the country. Lowndes County, Alabama. I'm going to look at some pictures in a minute, where people are dealing with some of the same conditions that Jack Geiger saw a half a century ago in the Mississippi Delta. And if you live in extreme poverty, it has direct effects on your health. It has effects on, obviously, if you can afford health care. We live in a state where with Medicaid, obviously people say, well, we have Medicaid in this country. Well, if you make more than 18% of the poverty rate in Alabama, you don't qualify for Medicaid. So if you make more than $4,000 a year in Alabama, you're too rich for Medicaid. So part of this is policy, right? Part of this is policy. We need change policy. So you deal with those types of issues, but poverty today still has a direct result on health. One of these issues that Geiger saw, and we're saying is still relevant today, is sanitation. One of the things that was horrifying to him when he went into Mississippi and his sanitary engineer was that there were towns where the white side of town was sewered and the black side of town was not. Those sharecropper shacks we saw didn't have toilets. They had sunshine privies, open privies, and they actually got to a point, this is the late 1960s, that they were building outhouses, building sanitary outhouses, because that was a better solution than what they had. And it was horrifying to them that they were saying, look, why are we having to build outhouses? We should be building sewers, but they didn't have the money to do that. So they're building outhouses because up to that point, when you had rain in cities like Rosewood and Alligator, Mississippi, there would literally be human waste in the black part of town. Eventually, that led to Supreme Court cases, Shaw versus the United States. Once again, we don't think of sanitation, we don't think of sewage as being a civil rights issue. There were boycotts, there were court cases. And Shaw versus Mississippi, which finally decided in the early 1970s, says, yes, a municipality can't decide to provide basic services to one part of town and not another part of town. And so, that was a struggle that was won in the 1960s. But we've also seen deterioration of a lot of these situations. This is Lowndes County, Alabama, 2018. There's sewage in the streets, sewage bubbling up because that infrastructure has gone out of working order and has not been replaced. So this UN report on poverty issued a devastating indictment of a lot of aspects of poverty in the United States. And if you haven't had a chance to read this, you Google it. It's not that long, but it's very devastating. And talking about the raw sewage that's found in parts of Alabama and parts of West Virginia. We've also looked at Puerto Rico and the problems there. And the fact that this is creating situations that health conditions that had gone away are coming back. One of the most devastating is hookworm. Hookworm is a parasite. It's something that had basically been eradicated by the 1940s and 1950s in the United States, because if you have sewage systems, you don't get hookworm. It's coming back, and it's a parasite that's now being found again in humans in Alabama and Mississippi because of the problems we have. So sanitation, basic things that pretty much everybody in here, I assume, takes for granted, that we have toilets. These are issues that are affecting health of our neighbors still today. Related to sanitation, of course, is water. There's another picture from the 1960s. We see another one of these drums. You can see there's a little spigot on it. I always think this is a powerful photo. Those shacks that Dr. Geiger came across in the 1960s, they didn't have sewers. They didn't have running water either. And so what many people would do, they would get these old 55-gallon drums from the plantation, and they would take them into the city, the municipal water supply, and they fill them up. Of course, these drums had previously held DDT and other chemicals on the plantation, right? You don't have to be a doctor to figure out that that's not good for your health. So they fought, and they got municipal water supplies built. Once again, the Shaw case dealt with sewers. It also dealt with water. 60 years later, we have Flint, right? And Flint's not the only city in the United States where we're dealing with water issues, right? It's become the most famous, but there are lots of places that are dealing with water issues, in part because that infrastructure has broken down and there's not been the political will to fix it. And if your water's not good, your health's not going to be very good. And like I said, we have Flint. There are cities, Baltimore, New Orleans, where the public schools kids can't drink the water out of the taps, out of the water fountains, because it's not healthy. It's got too much lead in it. Areas where there's fracking, there have been a lot of problems with the groundwater being contaminated. Coal ash ponds. Like I said, a lot of these issues we hear about only when they kind of intrude upon middle and upper class societies, right? When it just stays with the poor, we don't deal with it. But we're seeing a situation where with Flint, with the danger of coal ash ponds, especially in North Carolina with the recent hurricanes, the floods, now this water is getting into everybody's drinking water. And then it becomes, I was in Austin, Texas on Monday, talking about a lot of these same things, and we didn't have water when I was there because of all the flooding. Austin was going without water, and so that was causing a crisis there. So water, these are issues that all of us have to deal with, and these are issues that are directly related to health. Right? These social determinants of health. Another thing that Geiger dealt with when he showed up in Mississippi was massive malnutrition. He was horrified, and this is a malnourished baby that he's dealing with the extreme poverty and how that related to people's ability to get proper food. And Mississippi in the late 1960s, the Mississippi Delta, like the Arkansas Delta, like parts of Louisiana, like parts of Alabama, like parts of the Appalachians, many of these areas actually saw hunger getting worse in the late 60s. From the 1930s to the early 1960s, there was what was called a commodities program, a program to deal with taking excess commodities, flour, cheese, wheat, different things, and giving them to the poor. That gets replaced with the food stamp program in the 1960s. The idea behind the food stamp program was, one, it was going to give people more variety. It was also going to be good for business, right? You have to spend the food stamps. But the initial program, you had to buy the food stamps. You had to pay about 22 cents for every dollar. Where Geiger was, the average family made $700 a year. You make $700 a year, 22 cents to buy $1 worth of food was more than you could afford. And he saw nutrition getting worse, malnutrition getting worse in these areas. And so, one of the things he did, he had a federal budget, and he started writing prescriptions for food. He wrote them out of his pharmacy budget. You can imagine when people in Washington found out that he was writing prescriptions to local grocery stores for milk and eggs, they went bananas. They say, you can't do this. Prescriptions are for medicine. And he said the medicine for malnutrition is food. Of course, they couldn't argue with that. And they started setting up a new program where there was going to be a food relief. But of course, that doesn't solve the problem in the long term. That only solves immediate problems. We deal with malnutrition today. We deal with malnutrition in many different ways. 15% of the American population is food insecure. 40 million Americans are food insecure. 6.5 million children are food insecure in this country. And when we talk about malnutrition today, we talk about certainly not having enough to eat, but we also deal with the issue of having the wrong things to eat. One of the physicians that was in the original Delta Health Center, one of Dr. Geiger's colleagues, Aaron Shirley, was a fascinating guy. He was just a hero of the medical community in Mississippi. Dr. Shirley said, in the 1960s, people were dying of not enough to eat, because in the 2000s, they're dying of the wrong things to eat. And we deal with what many of you have probably heard about, of things called food deserts, right? Where if you live in an urban area or you live in a rural area, there may be a place to get food, but it's a gas station. And you can't get nutritious food. But it's also an issue of poverty. A 2 liter of Coke costs $1.50. Now, a gallon of milk costs $3.50. People are buying Coke instead of milk for their children. And so malnutrition is another one of these social determinants of health, and something that has not gone away. Right? We do have food assistance, right? And the food stamp program has been adjusted since it was in the 60s, but it is something that you probably all know is constantly under attack, right? Constantly being limited on who can qualify for it. And of course, it's important to remember it's not just people who are unemployed that need food assistance. Most big public universities now have food banks for their students. Half of all children of the armed forces, active armed forces, their children qualify for free or reduced meals. Right? If you work a 40-hour week at minimum wage, you still qualify for food assistance. So all of these issues, I just want you to think about as you leave today. Think about health beyond just my health insurance, my flu shot, my yearly visit, but think about all these other social determinants of health. Thank you very much.
All right. So I think that talk is really good. It kind of speaks to me in a special way because I grew up near Mountain Bayou, Mississippi, and about 3 hours south of Memphis. And I saw a lot of that poverty, and there was a lot of discrimination and health equity and health inequity, and really every sort of inequity that you could come across was present there, and that wasn't that long ago. So we're not talking hundreds of years ago. But I do want to boil things down a little bit more so that you have the correct definitions of these terms that are about 2/3 of the way down on your handout, just to make sure we're clear going forward. The big one, of course, is social determinants of health. And he talks about that a lot, but he sort of talks around the term. And so I want to tell you what that really is in case you are unfamiliar with it. It's really, he explains it as things that make people sick. And that is what it is, but that's a very simplified definition. So really what it is the conditions in which people are born, live, and work. It's factors like your socioeconomic status, so your money, your employment, which kind of ties into the socioeconomic status, education, social networks and social support, the neighborhood and physical environment, and then last but definitely not least, access to health care. And so when those things, those factors are really linked to lack of opportunity and lack of access. People are very often born into conditions that put them at disadvantage in those categories. Or maybe they come across a circumstance in life that puts them in a category where they are not able to get employment that helps them to learn or allows them to earn a living wage. And maybe they experience maybe some addiction or mental health illness, and that causes them to lose their home. They become homeless. So again, it's linked to lack of opportunity and lack of access in a way that's really unfair and unavoidable and inequitable. The next term on our list is health disparity. And it's very much related to social determinants of health, but the way I want us to think about health disparities is that's a higher burden of illness, injury, disability, or death that's experienced by one group over another. Due to problems with access and quality in health care. So those are two big terms that we're going to think about today, and think about the conditions that both contribute to those states and come along with those things that relate to the nervous system and its development and its ability to function. All right, so I want to show you, I listed this on the website. I mean, on Blackboard, I put a link to it, but I want to show you, let me get to it, make sure I'm sharing the right screen. This is an interesting tool that I came across through the CARES Engagement Network. And I really just entered the city and state where we are, and what came up is this graphic. So I'll interpret it for you so we can not spend too much time on it. But so it shows Memphis here in the middle, and you can see the different neighborhoods, or really they're divided by zip code. So 38103, 38104, and so on. And here's what the color coding means. If it is orange, that means that a certain significant percentage of that population lives below the poverty level. So more than 20% of the people living in that zip code live below the poverty level. If it's maroon or red, that means that they're above the poverty level. Most people in those zip codes. Where you see the purple means that the majority of people in those areas did not complete high school. So this has been an area of improvement for Memphis over the past 10 years, but the poverty level has not that much changed. It seems like where people are living, when those people make a living wage, when they're not living in poverty, that is not changing in our city. So that's an interesting report there, and you actually can filter that out to look at some different demographics, such as education level and marital status and all sorts of things. So you can peruse through that and look at it at your own pace. But I did want to say that this is a very relevant term and topic, social determinants of health in the city of Memphis, in the South, and in our country. There is a good deal of health disparity that is going on. One of the things that I've included in the follow-up information is a Memphis poverty fact sheet, and it's a PDF you can look at, and you can choose to download it and really look at what poverty looks like here in the Mid-South. All right, so I'm going to share my screen again, and we'll go back to the PowerPoint. Poverty has a huge impact on health. That's what really we're going to be talking about today. Here's a statistic that I pulled off that same website that shows the percent of people living under the poverty level in the US. It's about 15%. In Tennessee, it's about 17%. In Shelby County, it's about 20%. In the city limits of Memphis, it's at 26%. So slightly over a quarter of all people living in Memphis are living below the poverty level. That's why social determinants of health is so very important. And really, it's also why some of these other terms we're going to talk more about today, like cultural responsiveness, it's so important for us to understand. All right, let's watch a short video now on health disparity.
When we talk about health and healthcare in the US, I think that we would all like to imagine that everyone gets the same high quality of care. But this actually isn't the case. And a lot of the disparities that we see within the healthcare system in the US are the result of poor economic and environmental conditions. And I have SES written here, and that stands for socioeconomic status. And if we think about social class, we can think about it in terms of a pyramid, where we have the highest income and educational levels at the top and the lowest at the bottom. And as we go up this social pyramid, we see that access to healthcare gets better, and the quality of that healthcare also improves. And related to this, the health of those people at the top of the pyramid tends to be better as well. But the opposite is actually true for those at the bottom of the pyramid. And there are a number of reasons as to why this might be. First of all, high-quality medical services are more likely to be located in wealthy communities as opposed to poor areas or rural areas. Disease is also more likely to spread within crowded living conditions, and substandard housing might not properly protect people from the elements. Also, having a poor diet could significantly impact a person's health. And this is especially true for those living in food deserts, which are areas that have a lot of access to fast food, but have almost no access to supermarkets or fresh produce. Individuals with a lower SES are also more likely to take jobs that put them in dangerous environments, which could lead to accidents. They are also more likely to take jobs that involve significant health risks. As an example of both of these things, miners work in very dangerous conditions and are also at a high risk for conditions like black lung disease, which can result from breathing in the coal dust. Also, individuals with a lower SES simply can't afford expensive treatments and prescriptions. Race can also play a large role in healthcare equality. African Americans, Hispanics, and Native Americans tend to have higher morbidity rates or higher rates of disease and illness, as well as mortality rates or death rates. They also tend to have worse access to healthcare, and the healthcare that they do receive tends to be of lower quality. And although some, or maybe even many, of the racial differences that we see in healthcare can be attributed to the causes that we listed when we talk about SES, it does not explain everything that we see. Even when economic differences and even types of insurance are taken into account, minorities are still less likely to receive both everyday standard healthcare as well as treatments for life-threatening conditions. There are also many important gender differences in health and healthcare. For example, men typically utilize fewer preventative services, like vaccines and checkups, even when they are available to them. Women require reproductive services, and unfortunately, sometimes access to these services are reduced because of politics and local laws. And while a lot of attention is placed on finding treatments for conditions such as heart disease and diabetes, often these studies focus on men and don't always include women. And since symptoms of diseases can differ by gender, women can suffer from this lack of medical research. Another group that suffers from healthcare disparities is the LGBT community. These individuals might face discrimination from healthcare workers, which can often limit the clinics that they feel comfortable seeking help from. Transgender individuals especially may face a lot of discrimination from within the healthcare system, and they might have a hard time finding a healthcare provider who has experience working with transgender individuals and can cater to their needs. And this can lead them to be reluctant to obtain services when they really need them.
All right, so hopefully that kind of sheds some light on why we're talking about what we're talking about today. Because now I want to move into the specific topic of the impact of health disparity, social determinants of health, and the stress and trauma that living under those conditions has, and then the impact of that on the nervous system. It used to be thought that there was one factor that caused a certain disease or condition. For example, if somebody got a cut on their arm and it was exposed to it exposed them to some kind of bacteria, that's why they would get an infection. But what doctors and scientists and other healthcare professionals started noticing over time is that 100 people could have the same exact thing happen to them, and some people would have a better outcome and some people would have a worse outcome. So that made them start thinking, well, what is the variable? If we look at, if we only look at people that are the same gender, the same race, the same age, wash their hands the same a number of times a day, that sort of thing, what is the deciding factor as to who then gets a worse infection and maybe even dies from that infection, and who really doesn't even need antibiotics? Their body just fights that off through white blood cells and their immune system. So what is the difference there? And what they discovered, and what really has been proven many times since then, is that there is a significant relationship between health and variables that are behavioral, psychological, and social in nature. So we're going to talk about those variables. One concept that I want to throw out there before we get into talking about the variables is the concept or construct of health. That's a term that we throw around a lot, and it means different things in subtle ways to different people, but there are even really different ways to think about that. Sometimes health is thought of as the absence of disease or injury. And when we talk about it that way, we're really talking about it in a negative term because we're taught thinking of it in terms of what's not there, those problems, the diagnoses. If we think of health, though, in terms of wellness and your well-being and what is there, then that is really a way of thinking of it in a positive light. So we think of that as positive health. And both are correct. It's just really two different ways of looking at it. And you could see how, depending on which way a person or a healthcare facility or company or really even society tends to view health, would lead them to do different things to support it. So if you are of the mindset that health is a negative concept, and you're in a good status if you don't have disease and illness, if you avoid those problems, then you're going to be more focused on, say, infection control and stocking your medicine cabinet with things like Neosporin and antibiotics. If you are more of the mindset that health is related to wellness and it's a positive health concept, then you're going to look for things that are more probably holistic and think about prevention. You're going to do things that boost your immune system so that you don't even need those other things that are maybe associated more with what they call negative health. Now, there is some controversy that comes with the term positive health in our society in the US, and it really, I think, is because it's sort of related to the top-down and bottom-up model that we talked about a lot in foundations. It's because it's more of an Eastern medicine concept. How do we ward off problems by doing things that are holistic and health promoting rather than doing things that treat the illness more reactively, whereas the positive health concept is more proactive there. So something to think about, and it is something that it seems like our society is starting to make a switch towards. And I do think that with the pandemic, we are seeing both sides of that. And sometimes the only control we have or what we can control more is our positive health. And so more people are starting to turn to boosting their immune system and having good habits and routines that instill wellness. And even practices like meditation and mindfulness and exercise and things like that. So let's think about the factors that are related to health that I mentioned a few minutes ago. Those things that really influence if someone has an illness or an injury, if they are exposed to something, is their body able to be resilient, or are they more at risk for succumbing to it and then needing medical intervention or even having an irreparable outcome, such as permanent disability or death, if they do get that illness? So one set of factors is called the biobehavioral factors. What that really is it's the psychological and the physiological. So it's your mind and body working together in response to stress. And we talked about in a previous session that the body seeks balance. It seeks homeostasis because the body really doesn't want change to occur. So it's always trying to even things out and keep things the same. Now, when stress is experienced in a severe and or chronic way, it takes its toll on the body, including the nervous system. And there's a term that you may not be familiar with that I want to bring up. It's allostasis, ALLOSTASIS. And that's really the process of adapting to that stress as a way of seeking the balance. So here's maybe an easier way to understand that. If you are a person who lives in a household that's pretty chaotic, maybe there are even individuals in the household that have anger management problems or health problems themselves, and there's a lot of demand on you in that home environment. If that's a change for you, so if you just start living in that environment, it's going to be very disconcerting and upsetting, and you will lose sleep over it, and you will notice the stress of it. But if you're in that environment for an extended period of time, even if nothing around you changes, your body changes to adapt to that. And so then you enter the state of, or you go through a process called allostasis to adapt so that you're used to that higher level of stress. And that's the body working towards homeostasis. So allostasis is a process of adapting to challenges or stress. Now, a sort of an offshoot of that term is something called allostatic load. And that's the wear and tear on the body that it has to go through in order to get to that point of being used to the stress. So as your body adapts to that, like in the example I just gave, as your body adapts to it, your blood pressure may go up and it may stay up. You may have more headaches or stomach aches or GI problems. Your eating may kind of tank because you're living in a more state of chronic stress. And so you have to pay attention to things that are related to survival, or you may seek comfort by eating junk food. Whereas you didn't do that before. You had the bandwidth to pay attention to healthy eating and other things like exercise and getting enough sleep. But when that chronic stress happens, your allostatic load is something that influences the nervous system. And that's a big part of the biobehavioral factors that impact our overall health and certainly our nervous system health and function. So that's one set of factors, the biobehavioral. The next set is that we're going to talk about today are the behavioral factors. And so these are, you could say, choices that we make or habits or actions or behaviors that we have as individuals that impact our health. It's things we can choose every day. And then if you make the choice to do something or to not do something every day, it becomes a pattern or a routine for you and can impact your health on a larger scale on a longer term basis. So some obvious examples of these behavioral factors are things like physical activity, diet, tobacco and alcohol use, sexual practices, safe sex, and disease screening and vaccines. Is it something that someone does? Is it part of their behavior to choose to get those services if they are able? Do they get eye exams? Do they, are they getting yearly physicals? And then just the everyday choices. Are they couch potatoes, or, are they over exercising? Those kinds of things. And so when we look at those things, we can see where those things would have an impact on our overall health and our nervous system. One impact, just for example, and sometimes we can look at a couple of those factors. So let's look at diet and exercise. It's something that's talked about a lot in the media today. If someone has a behavioral pattern of not paying attention to those things, those two factors, then very often what happens is they become overweight. They may have trouble with their blood pressure, even their blood sugar. And that creates more serious long-term health consequences, such as heart disease and diabetes. So that's how behavioral factors can influence the body, and then those things can contribute to problems with the nervous system, such as increased risk of stroke. It could even be that if somebody has very poor diet and exercise, that their balance isn't as good. Their core strength, their balance, and so they're more at risk for falling. Then they're more at risk for accident that might include a brain injury. So it's sort of a chain event that happens there related to those behavioral factors. Now, the last set of factors we're going to talk about that are related to health are the social factors. Most behaviors really aren't that random when we look at the population as a whole, but they occur in something that's called a social pattern. So an example of this is people who have a lower socioeconomic status, so people who are poor, who don't have financial means, they tend to have a lower level of education. They don't go as far in school. This is, in general, but these are the patterns that have been observed in research. And oftentimes then they don't have access to things like a gym or a neighborhood that's safe to walk or play in. And so those types of things start having an impact on their health. They might be more apt to participate in risk-related behaviors like drinking or not using sunscreen, or in this day and age, not wearing a mask, because of their social system. We tend to kind of follow the lead of people that we flock with. And if people are not staying home, if they are not washing their hands extra, if they are not wearing masks in public or practicing social distancing in a very serious way, then that is going to impact their health because of their social environment. So those social environments do shape our norms. They also impact what we think of as our own control over our health. There are sometimes groups of people, women who will remind each other to get their yearly mammograms, or support groups who help each other stop smoking. And if you don't have access to that, or it's not really readily available, learning how to cook healthier, those kinds of things, then it's harder from a social standpoint to move towards a better state of health. So they don't really have as much of an opportunity given their social environment. And there's another thing that has to do with the social factors when it comes to health disparities, and that really is some research that's come out fairly recently talking about social connection, or sometimes it's called social integration. And it's just basically, if you are around other people who are healthy and who make you feel supported and cared for, your own health tends to get better just through that connection. being in a situation like that helps change your mindset. It helps change your behavior patterns. And it helps change your habits, like going for a walk instead of, sitting on the couch, doing something healthy instead of doing something unhealthy. And that not only keeps your body healthier, but also your mind and your spirit as well, and leads to a longer lifespan, better quality of life, better life satisfaction. And not only do you live longer, but you are healthier while you're alive. So when someone lives in a situation of chronic stress, there are certain aspects of the nervous system that are involved in that stress response. And we've already talked about all these, but just to kind of go back through them and highlight the ones that are involved here. The brainstem that controls life functions and, secretes some hormones like adrenaline and epinephrine. So if the stress is causing somebody to breathe faster and their heart rate, their pulse gets faster, sometimes their face will turn red, they're having extra blood flow there, that really is related to the functions of the brainstem. The limbic system, that's the one you could probably easily guess. And the midbrain has a small part, and that is something that controls vision, hearing, the taking in the sensations. But the limbic system is the big one. And you know that to be the collection, I guess, of brain structures that's just under the cerebrum. You can kind of see it in the picture here. It includes the hypothalamus, the hippocampus, and of course, our friend, the amygdala. The amygdala being tied to fear and emotion, and a little bit to memory. And the thalamus, where that sensory information is taken in and processed. The hypothalamus, that has to do with circadian rhythm, thirst, hunger, and autonomic nervous system function. And then the hippocampus, which is also tied to turning things from a short-term memory to turning them into a more long-term memory. The cerebellum and the cerebrum are also involved in the stress response. You could probably have guessed that. The cerebellum, remember, being balance and movement, posture, regulation of those types of things. So if you are stressed, your body is paying attention more to survival than to coordination, learning new motor skills, things like that. And the cerebrum, being the thinking part of the brain, especially in terms of reasoning and language and visual processing, looking at things, so reading, those things, all impacted by stress. Now, those other systems are typically ramped up when someone is having a stress response. And again, the brainstem, we experience a speed up of everything. The amygdala, it's, running on high drive because there's all the fear, even if you are moving towards an allostatic state. So if you're getting used to the higher level of stress. But the area of the brain that does the opposite is the prefrontal cortex, or the PFC, which is really our logic center. If you are in a state of stress on a short-term basis, you can do without your prefrontal cortex. Your brain is more involved in surveying the environment, processing what to do, and then getting out of there, or hiding, or, flight, fright, all that. So that's what the brain's trying to do. And what the brain's not trying to do is learn things and reason it out. Think about higher order thinking. That's not what it's trying to do. So that stuff gets kind of put by the wayside, put on a shelf for a little bit. The problem, though, is if that crisis is extended. If the person, so maybe go back to that example, if the person is living in a home that's very stressful, and this is going on for a long period of time. So their body starts to get used to that. They go through that allostasis, adaptation. But the prefrontal cortex is impaired because it's not working at full capacity. It's not seen as a priority to keep it going by the body. So it's harder to make choices. It's harder to think about things logically. It's harder to control your behavior with logic and judgment. So if you think about a pros and cons list, should I do this, or is that going to get me in trouble? What's a better way to handle this fury or other emotion? That's what our prefrontal cortex normally does for us. And in a situation of very acute or extended chronic stress, that's not happening. So it shuts down, or at least operates at an impaired capacity. All right, so let's take a few minute break. I want y'all to walk around, stretch, get something to drink, and then we'll come back and kind of talk a little bit more about this topic before we move forward. So let's just step away for 4 or 5 minutes, and then we'll come back and continue. Sharing screen, there we go. Okay, any questions or comments about what I've been talking about? It's kind of complicated stuff, but in another way, it makes sense. If you think about all that we've learned and what we know and what you've experienced or seen, it does make sense. And you can, I hope, see why it's really important for us to talk about this. All right, I'm going to show a video that's a couple minutes, a little bit short of a couple minutes long, that talks about something we've talked about previously in this class, and that's the hypothalamic pituitary adrenal axis, or the HPA axis. And that has to do with the stress response system. So let's watch this video. Whoops.
Neuroscience topics in 2 minutes or less. In this installment, I'll discuss the HPA axis. The hypothalamic pituitary adrenal, or HPA, axis is best known for its role in our body's reaction to stress. The HPA axis includes a group of hormone-secreting glands from the nervous and endocrine systems, the hypothalamus, pituitary gland, and adrenal glands. Neuroscience topics in 2 minutes or less. In this installment, I will discuss the HPA axis. The hypothalamic pituitary adrenal, or HPA, axis is best known for its role in our body's reaction to stress. The HPA axis includes a group of hormone-secreting glands from the nervous and endocrine systems, the hypothalamus, pituitary gland, and adrenal glands. The hypothalamus is a small neuroendocrine structure situated just above the brainstem that controls the release of hormones from the pituitary gland, a hormone-secreting gland that sits just below the hypothalamus. The pituitary gland can release hormones into the bloodstream to reach a variety of targets. In the case of the HPA axis, hormones released from the pituitary gland travel down to the kidneys and influence the secretion of hormones from
Sorry, I don't know why it's doing that.
endocrine glands called the adrenal glands, which sit on top of the kidneys. The primary function of the HPA axis is to regulate the stress response. When we experience something stressful, the hypothalamus releases a hormone called corticotropin-releasing hormone, or CRH. CRH signals the pituitary gland to secrete a hormone called adrenocorticotropic hormone, or ACTH, into the bloodstream. ACTH travels down to the adrenal glands, where it prompts the release of a hormone called cortisol from the cortex, or outer layer of the adrenal glands. The release of cortisol causes a number of changes that help the body to deal with stress. For example, it helps to mobilize energy like glucose, so the body has enough energy to cope with a prolonged stressor. When cortisol levels in the blood get high, this is sensed by receptors in areas of the brain like the hypothalamus and hippocampus, which leads to the shutting off of the stress response through what is known as a negative feedback mechanism.
All right. So when we look at the HPA axis, it's got those three components to it: the hypothalamus, the pituitary gland, and the adrenal gland. Now notice, if you look at the picture on the right-hand side of this slide here, you'll see those three areas of the body, but notice that two of those are in the brain and one of them isn't. The adrenal glands are really not in the nervous, they're considered part of the body rather than outside of the nervous system, but they do have a role in the HPA. So they're related to those other two areas. Now, all three of them secrete hormones, but only the adrenal glands secrete a hormone called cortisol. Now, I'm guessing you guys have heard of cortisol. That is what is called the stress hormone. You can get a blood test, and you actually can get even a saliva test and have the level of cortisol in your body measured. And sometimes you don't realize that you've been under that stress. It may be how you're adapting to things. So if you have gone through the adaptation process and you're sort of used to it, you may not be experiencing a lot of the bodily symptoms or even just noticing it, but yet your cortisol level is still high, abnormally high. And so that brings with it a whole bunch of problems. One is trouble losing weight. It may be, and in fact, you often will gain weight if your cortisol level is high. It's the body thinking that it's under attack, so it's trying to preserve its energy just in case. It also increases your risk for diabetes and there's a whole host of problems that come along with a chronically high cortisol level. So it's not something that we like to see in the medical field. And it is related to stress. Something else related to stress we've talked about is the limbic system. And I wanted to again put this picture up to show all the things that are related to stress that have to do with or are situated around the limbic system. But I want to underscore that the amygdala really has the most powerful role in the brain response to trauma or stress. And the role of the amygdala in stress is to help you pay attention to the correct things. So it sort of filters out things that are not as important. You don't need to know what people around you are wearing if you think you're having a heart attack. It helps you focus on survival and other relevant and very important things. Okay, something else on your handout that I want to make sure we talk about. We talked a little bit about cortisol, and I'm talking about more about that, but the fear circuitry. And so the amygdala is the captain of that team of the circuits that you see. In trauma and high or chronic stress, what happens because of all the brain structures, chemicals, and actions in the brain that are related to that is, again, the prefrontal cortex slows down or shuts down. And that's really a chemical response that causes it to do that. And it's related to cortisol. So cortisol does diminish the function of the PFC. Now, your attention or your focus is on survival. It's prioritizing. What is it that you need to do to survive in a stressful situation? Now, interestingly, some of the other changes in the brain that happen in these high and or chronic stress situations, besides the function of the PFC being slowed or shut down, is the amygdala ramps up. In fact, it does that so much that it's the tissue starts to grow. So that area in your brain starts taking over more real estate. That allows you to have more capacity to process emotions so that that can happen faster. Another thing that happens in the brain is the number of connections and the overall size of the hippocampus are reduced. So what that translates to in terms of function is it causes problems with remembering certain details and sometimes even the sequence of events that happen. So if you think back to a time that was really stressful for you in your life, it's likely that you remember some details, but not everything, even if it just happened very recently. And even if when it happened, you thought, I will never forget any of this. So think about if you've ever been in maybe a car wreck, even a fender bender. It's stressful and it's scary, and your cortisol is really pumping, and your brain stem and your amygdala are really in high gear. And what's hard sometimes is you're being asked to make decisions like, do you want to call the police, or do you want to call someone to help you decide if you want a tow truck or if you think your car is drivable after a wreck, something like that. And your prefrontal cortex is taking a vacation because of the fear circuitry. So over time, if somebody is in a fear or stress situation like that, the size of their hippocampus decreases, the number of connections, synaptic connections in the hippocampus decreases. The prefrontal cortex is impaired because of chemicals, including cortisol, that are going on, and your amygdala grows. All right, I got one more short video, and then we'll be ready to kind of wrap up a few more terms, and then we will be done. So let's watch this. Is a 6-minute video. There we go.
So it's important to know that white therapists can be anti-racist therapists. And what I mean by that, as opposed to just cultural competence, right? Cultural competence is often about like, have you learned some information about different communities? Do you have some sense of your own identity? But to have an anti-racist stance is more active. It is more intentional, and some directories or mental health networks have started educating communities of color to tell them that it's a small percentage of psychologists and mental health professionals that are ethnic minority. And so as they're looking for therapists, and even you can have an ethnic minority therapist who does not have that consciousness around being actively anti-racist. So what these networks are recommending to people when they call to look for a therapist is to ask them, what are your thoughts about the impact of racism on mental health? What are your thoughts about the impact of white supremacy on mental health? As a taste test, like a measure of, and if the answer is, well, I believe people are people, well, then there you have your answer, that this is not someone who is going to be able to acknowledge and engage with you because they're not even willing to acknowledge that it exists and that it has an impact, right? And so it's important to be able to communicate awareness and compassion that these events are happening, that oppression is a reality now, right? So that historical piece is helpful to know. And it is very, very important to be able to not go into victim blame. So when we go into trying to defend and explain people who have said or done harmful things, then it lets the client know this is someone who is not really safe for me. They're not really for me. And what it requires from us, when I say from us, I mean, whenever you're a part of the majority group, is to release my defensiveness, because our usual tendency is to connect with the person we see as a reflection of ourselves, right? Because if the mom did something bad, then maybe that means I do something bad, so that I need to make it okay, right? And so, the example that comes to me from my own experience is around working with clients with disabilities as an able-bodied person. And I was teaching multicultural psychology, and I had a guest presenter who uses a wheelchair, and she was talking about coming across the campus, this place where I used to teach, and the invisibility of systematically everyone refusing to look at her, right? That no one, as she came across the campus, no one would look at her. So in my able-bodiedness, what my defensive instinct, which I didn't speak of, but what came to my mind was, I know what that is because I have done it in terms of trying not to stare, looking away, right? Without ever taking into consideration, what would it feel like if everyone does that? If everyone is averting their gaze, right? And again, that difference between intention and impact. Even if you did not intend to be rude or mean, that it is an erasure, right? And so to be able to sit with that, and that's what I would say for white clinicians when ethnic minority client is describing an experience, your instinct may be to try to figure out how they could be interpreting it incorrectly, right? Because we want to believe that things are fair and right, and maybe I would do that, or maybe my cousin would do that, and we're not bad people. But instead to really sit with, what is it this person is saying, and what, we cannot fully imagine, but what might it be like to have that experience? and then to respond with that support. And I want to say, actually, that that can be very therapeutic and healing in a way that hits on another level than them hearing it from me, right? And what I mean by that is when I've had rape survivors who were raped by a man, had a male therapist tell them how wrong that was of what happened to them, it registers in another way because this person, in some ways, they identify with that group, right? And so instead of feeling powerless, like, oh, I won't be able to help my ethnic minority clients, instead, with humility, because people have talked about now, not just cultural competence, but cultural humility, which is, I don't know everything, and a continuous learning and an openness and a recognition. So with humility and compassion, that this could really be a therapeutic moment. It could really be healing.
All right, so I went on and put the terms that were mentioned in this video and related terms. We've talked about some of these before, but I went on and defined those on your handout, so you have that. But do remember, you're not just memorizing that. I want you to think about what the distinction between those different things are. We learned about some of that in foundations, and I remember that some people did not get that right on the final. What's the difference between the cultural competence, responsiveness, and humility? We really, in a more updated sense, are starting to use responsiveness, but humility is an update to competence. And so if you hear people say cultural competence, that really is an older model. It's something that we are trying to move past. And so the last thing I want to say to you, and then I'll see if anybody has questions or comments, is that I am one of the co-facilitators for a community of practice. It is a bunch of OT practitioners and students that meet together once a month online. We've been doing it for several years, and it's free. Anybody can do it. It's organized through the TNOTA, but you really don't even have to be a member to do it. And we usually focus our topics around pediatrics, but we also try to expand and do some broader topics. And this coming Monday at 7 p.m., there will be a talk, and it's just a conversation about how we can elevate our cultural humility, especially in the climate and things that are going on right now in the world, in the U.S. And we're going to have a conversation about that. And you all are invited. You don't have to come, but if you do come, you can count it for service hours. And you don't necessarily have to say anything. You can just come and listen, but you are also welcome to come and contribute. So there's the information on that. If you would like to join to kind of continue some of what we've talked about today. I know there's going to be a lot of resource sharing at this, and so that's something else that you could get out of it. All right, well, with that, I'm going to stop sharing and open up for questions or comments. Anybody want to chime in about any of this?
I have a question.
Sure.
Are the terms cultural intelligence and cultural safety, are those new terms that we're using in place of something like with cultural responsiveness and cultural humility, or are they just added on?
That's a really good question, Lucy. They are really just added on. So cultural intelligence, you probably could kind of guess what that is. That's more like your aptitude or your skill set or understanding about cultural responsiveness. So it's kind of your level of cultural responsiveness, I guess. It is a marker of your own abilities. So it's kind of like awareness of where you are in your learning about different cultures and and getting better at interacting with people from different cultures. And cultural safety, it's been around for a little bit longer, but it's just not as talked about in general circles. It is more of a two-way exchange. So it's the relationship, kind of a therapeutic relationship, or the feeling that happens between usually a healthcare provider and a healthcare recipient, or a client, as we call them, and how that relationship works in regards to the culture of the client. So they're all very closely related. It's just kind of something for you to, it helps me if I can read more about it and talk about it and, kind of process it that way, because they are so close and they can be so complex too. So I'm glad you asked that. They're additional. Health disparity. Let me talk about that again. It's the unfairness, or really the extra burden that somebody, a group, or a person can experience because they don't have as much access to good health care. So you could think of it as maybe the disadvantage or the burden that a group or a person has because they don't have as much access to good health care as another group or person. And the reason they might not have that much access, or what they can access is not good quality, is related more to social determinants of health and those factors that we talked about that influence that. Anything else? And it doesn't have to be related to this class, to this session. It could be whatever. All right.